Okay, so I think we've just turned 12:30. So hello and welcome to Day 3 of Clinical Audit Awareness Week and Day 3 of the Lunch and Learns that we're collaboratively running with HQIP as part of the week. So my name's Vicky Patel. I'm Chair of the NQICAN Network and also Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust, chairing today's Lunch and Learn alongside Marina, who's our NQICAN General Secretary. So you'll see Marina up on the screen. Theme today is health inequalities. So it's all about how we're utilising clinical audit to effectively address health inequalities in improving health and care. So you'll notice the event's being recorded. It would be lovely to see your cameras on if you're able to. Chat function is live, and we do ask if you could please remain muted to allow less noise for our speakers and the recording, and we'll have the opportunity for questions as we go through and at the end. So if we just move to the next slide, please, we'll be able to see the Lunch and Learn events for the week. So Monday and Tuesday we held patient safety and patient and public involvement lunch and learns. Slide packs and recordings alongside further resources will be published as soon as we can on the HQIP web pages and the NQICAN Future NHS workspace as well. Today we are talking about health inequalities, and we've got Danny Keenan, Medical Director at HQIP, and Dr. Charlotte Richardson, who's the Clinical Fellow at the National Healthcare Inequalities Improvement Team at NHS England. You'll see tomorrow we'll move that focus onto change with us welcoming back Sam Riley, Director of Making Data Account at NHS England, and she'll be helping to support us in effectively influencing change. And then as we round up the week on Friday and really start to think about the impact that clinical audit has on improving health and care, Zoe Lord from NHS Horizons will look at how we ensure change is actually sustained over time to really future-proof health and care. So if we move to the next slide then and just touch on anything that I might have missed from today's agenda. So we'll start with just setting the scene, touching on previous years and highlighting some key points really for you to consider today. We'll move over to hear from Danny and Charlotte. Then they're going to announce our winner of the Health Inequalities Clinical Audit Hero Award, and they're going to present about their experiences of utilising clinical audit to address health inequalities. There'll be the opportunity to ask questions. We do encourage you to keep posting into the chat. If we can't cover all the questions, we'll collate a Q&A to publish post-event, and then we'll be running an interactive evaluation in the last 5 minutes. So please do stay with us because we really, really want to know your thoughts. So if we move on to the next slide then, as we've done in the Lunch and Learn so far this week, it's just touching on how important Clinical Audit Awareness Week is for our clinical audit and wider QI community. And it's not just 1 week in time, it's shining a light on everything that we're doing every day within our roles to improve health and care. So we touched on this on Monday and Tuesday, how NQICAN's got 10 regional networks. We're just going to pop the link to the contacts into the chat for you to get in touch with us if you're not yet a regional network member. The regional networks are quite actively involved in delivering NQICAN's forward plan and our improvement priorities. Regional networks send the voice into the national NQICAN network and also take key messages and voices back into the regional networks as well. Our quarterly NQICAN meetings are held on MS Teams, free open access links that are shared. Next meeting's 10 till 12 on the 24th of September, so we'd love to see you there. We've got 2 workspaces now on the NHS Futures platform. We've had a networking and sharing forum for NQICAN for a number of years now, about 6 years, I think. And it's a good forum for you to network with your peers around all things clinical audit and improving health and care. And as of this week, we have been really excited in launching the forum now on the Future NHS workspace. So again, we're going to pop a link into the chat so that if you haven't joined this week, that you can head on over and put a request in to join. So we've got an NQICAN workspace that's very much networking with your peers around local clinical audit, and then we've also got a knowledge and learning hub around taking action on national clinical audit. So 2 different workspaces. You can log in once for the day into Future NHS and move seamlessly between all the workspaces that you're actually a member of. So we do encourage you to join and to be networking with your peers. So as we've shown you in the table already for the Lunch and Learns, this week touches on 5 themes. It's focused on how we effectively use clinical audit to support each of these. And today we're going to touch on key points, hear from our speakers, and obviously set you all further challenges to take away. On the NHS Futures workspace, we've got Clinical Audit Awareness Week set up. We'd love to hear from you in terms of your local plans and things that you're taking forward in your organisation that we can share amongst all of us so that we're learning together. So if we move to the next slide, you'll be able to see what we challenged you with last year when we touched on health inequalities, and it was very much looking at how your strategy and your policies aligned with your organisation's agenda and priorities to actually reduce health inequalities. How you're actually engaging the patients and public so that you're actually aware from their perspective where we need to make improvements in terms of maybe equity and access for all. And we also asked you to look at different groups and if actually standards of care, there was variation between them. And finally, your improvement plans, your outcomes and improvement plans from your clinical audits, if we were taking those forward with that focus on reducing health inequalities. So we'd love to know how you got on in the last 12 months. So please do get posting in the chat in terms of anything that you've been able to take forward, any challenges that you might have faced, how you've overcome them, or where you might need support from your peers to maybe address them. So finally, on the next slide, then it's just teasing your thoughts a little bit before we hand over to Danny and Charlotte, really, in terms of some key things to get you thinking today as we hear from Danny, Charlotte and our Clinical Audit Hero winner, and then for you to take back to your own organisation, really, so that you can take things forward. And I know historically with clinical audit, we've always said, oh, you can't collect demographic data, it doesn't fit with the data principles, etc. It's got to fit the purpose of the project. And we've almost done a complete U-turn now where we're supporting our clinical teams to really start to incorporate some of that data into their data sets so that they can now start to look to see if there is a variation in health outcomes for any particular groups and to make sure that we're picking up on any unwarranted variation. So it's trying to take that back now and think, right, how can we build that in every time we get a clinical audit project submitted in terms of looking at their methodology and making sure that they are including data that will help them address health inequalities, particularly focus on equity and access as well. Can all of our patients access our service in the most equitable way for them? And where we are identifying that difference, that we are then starting to build those improvements into those improvement plans, and that we do actually go back and involve our patients and public in terms of perspectives of have we actually got that right. So we touched on that yesterday a lot in terms of PPI involvement, but actually when we're looking at trying to address some of these health inequities, we may feel that we're making the right improvements and making that difference, but actually we've got to capture that experience and feedback, and particularly from our marginalised groups, which are often the harder to reach groups as well. How have their experiences been, and actually what more can we do to improve? And then I suppose final point here that I've not touched on really is that information in appropriate formats, and also that level, the right level of involvement in decision making for certain groups as well, just to make sure that this is equitable for all. So I think that's probably just a few key pointers to get you into that thinking mode around how we can make things better. So I think at this point, Danny, we'll hand over to yourself.
Well, thanks very much, Vicky. It was great, and thanks for the invitation. I was really happy to present this work that we've been doing and link in with Charlotte, the NHS England work. I also should thank all the colleagues who've been put a huge amount of work to put this all together. Yourself, Vicky, Marina, Lacia, Amanda, Caroline, thank you for all the work. And finally, thanks to everybody who's been doing so much work out and about. We will be announcing 3 winners for the competition, but we understand there are lots and lots of excellent submissions. So, and when you're starting looking into this, it is a complex area. The more colleagues we have looking into this, the more we're going to drive in and find out what's at the kernel of this, how do we make it better. So if I could have the next slide, thanks. So I'm Danny King, Medical Director of HQIP. I'm seconded from the Manchester University Hospitals, where I'm Associate Medical Director. If you just hit the next slide, thanks. So this work I'm going to present was done by our fellow, Alice Bradley, and indeed Charlotte was the NHS England fellow. So we have a long track record of our fellows doing work on this. Alice Conway was a medical student, so we actually got a lot of brain power coming in, helping us looking at this problem. 2 previous years, we had our fellows looking at audits. They picked up audits randomly and looked, well, what are these audits showing us about ethnicity and deprivation? And the unfortunate answer was actually not a lot, which was very disappointing. So whilst every audit virtually will always be looking at outcomes for patients based on age, sex, and a few other basic characteristics, ethnicity really wasn't in there. And so we thought, well, we have to get to this. We have to understand why this is. It's not. There's obviously a reason for this. So essentially, Alice, our fellow, moved to do a survey. If you hit the next slide, thanks. A survey of all of the INCAAW providers. And it was like a straightforward survey, and it was asking them a whole series of questions as to why were we not seeing ethnicity and deprivation coming out better when we look at outcomes for patients as seen in the audit programme. I'm going to show you a slide later with a link, but what I'm actually going to do is I'll put links to the definitive paper that Alice Bradley and Alice Conway put together, and I'll also put in a link to a blog that I put out this week, trying to bring this to the fore. This is such an important area that we really need to hit home on this. So I'll put those links in after I've passed on from this. So we did this survey.
Danny, just to interrupt, I've put those 2 links in the chat if anyone's interested, the report and the blog.
Perfect, thanks for that. So I can relax then after Charlotte goes on. Think much more carefully about what you're going to say, Charlotte. So thanks again for that, Alicia. If you hit the next slide, thanks. So what did Alice find? And Alice Conway, I really do commend reading this, because what Alice Conway added this was a huge amount of the science behind looking at ethnicity and deprivation when we're looking at healthcare information. So there's a really very an academic part of this paper that's very helpful for those that really want to delve in and get to what's going on here. So what did Alice Bradley find? So firstly, if you break it down into the different types of data that we've got, and a lot of the data coming into a national clinical audit is routine data. And here are the answers coming back from the audit providers as to why they weren't able to delve more into outcomes for patients based on the data that we're getting in from the audit. So, and the routine data basically what comes at this in this area was HES data. So it was incomplete data. And then problems with coding. I suppose this was predictable. Nevertheless, it was very good to tie it down and say, well, these are the problems. So incomplete data, difficulties with categorizing coding, and then unbelievably multiple ethnicities put in for the same individual patient. And you can imagine why, if somebody's pitching up multiple times and maybe parents putting in coding, you can imagine all kinds of different reasons why you might get multiple ethnicities coded through routine data. And then secondly, we have sets of bespoke data for national audit. Obviously, we're moving from that, but nevertheless, what did we find when we looked at bespoke data set? And the first thing was the time pressure to the clinicians. When bespoke data is being used, it means somebody is actually entering data into a spreadsheet or whatever. Time pressure, and everybody on this call will know about time pressure. And then accessibility and engagement challenges. It's not that easy sometimes when you're trying to get everything together and a patient's moving in front of you, so to speak, to get everything in that you need to get in. And then finally, consent issues. There are sensitive issues with certain groups, and you'll all have come across this, who aren't particularly keen to be giving out ethnicity area information. And so these were the big problems that the audit providers were coming across, so preventing them getting much better reviews and analyses of outcomes. If you just hit the next slide, thanks. Then the other areas that we hit on, population data. So when you're running an audit and you're getting results coming out, you want to be getting back to the baseline. So what is the situation in the United Kingdom, Great Britain, England, whatever area you're looking at? And it was actually not that easy to get complete data for comparison. And then unfortunately, cost is probably the wrong word. Those who analyze data are a very rare breed. They are very hard to get. When you get a good analyst, you want to hold on to it. They are not the highest paid. And so having analysts who do work on this is really important. And across the board in NHS England and elsewhere, we have troubles with keeping and getting analysts. But if you start adding in additional fields, and we must do that. Don't get me wrong. This is not something we want to shy away from. We must do that. But obviously the costs go up because the number of analysts needed to do this goes up, and that's something that we can address. And then finally, the small numbers issue. And so if you've got, I think it is currently 16 codes, whatever it is for ethnicity. If you're on small numbers and you say, oh, we'll just put it back to 5, you've lost the whole plot, because essentially, you do need it broken down by the 16, by whatever it is, not by 3 or 4, because essentially, that's getting back to anecdote style. So small problems is something that we will want to address. And you can see there the links, and Leslie will have those links in. So please do go and look at these 2 papers, because they give a huge amount of extra information. Okay, so I've done my bit. So this is like the warm-up act really for Charlotte, who's going to come in now and do the main event. So I'm going to hand over to Charlotte now. I hope there'll be plenty of time for questions. I've seen Charlotte's slides. It's a fascinating set of slides Charlotte's got, because we are starting to see some answers here coming through, which is brilliant. So much effort going into this, and now some answers. So Charlotte, I'll hand over to you. Thanks very much.
Thanks so much, Danny, and thank you for the invitation. So as Danny said, I'm Charlotte. I'm a clinical fellow working in the National Health Inequalities Improvement Team. If you guys wouldn't mind flipping the slide forward too. So on the next slide is the definitions of health inequalities. On the next slide. So we know that they are unfair and avoidable differences in health status between different groups of people or communities. And the key word here is avoidable. So these are things that we can intervene in and make a difference. And it's not just outcome that we see inequalities in, it's also relevant that there are inequalities in the access to healthcare and the experience of healthcare. So on the next slide is some of the data. So we do have lots of data at a national level, at a population level, really showing these stark inequalities. So this is data from the Health Foundation, looking at the difference in life expectancy and healthy life expectancy between different deciles of index of multiple deprivation. So blue is life expectancy and red is difference in healthy life expectancy. And you can see from the top bar, the most deprived 10% of the population have a 7 to 9 year difference in life expectancy compared to the least deprived at the bottom. And in terms of healthy life expectancy, so the years of life people can expect to live in good health, there's almost a 20-year difference between that top and bottom group. And it's and we can also see this represented in data on access to healthcare and experience of healthcare. Again, it tracks alongside those deciles of multiple deprivation. So if you could go on to the next slide, as well as the deprivation, we also see stark ethnic inequalities in health in the UK. And there's some excellent data and reports from the NHS Race and Health Observatory on this, with this summary graphic of all the different ways in which inequalities have been discovered. So on the top left, this is mirrored in the data from the Embrace report. Black women are 4 times more likely to die in pregnancy or childbirth in the UK. And we see higher mortality in South Asians from cardiovascular disease, and aspects such as blood donation and organ donation inequalities also have an effect on healthcare. And looking at other groups, the differences in life expectancy can be even more startling. So in Gypsy, Roma and traveller communities, life expectancy is 10 to 25 years shorter than the general population. Those people suffering from a severe mental illness also have a life expectancy decades shorter than average. And on top of that is the impact of intersectionality. So when somebody has two marginalised identities in society, this results in compounded discrimination. So for example, somebody with both a learning disability and coming from an ethnic minority background has an even more significantly reduced life expectancy. So on the next slide, we can make the case that in addition to the moral argument for tackling healthcare inequalities, there's actually also a business case or an economic argument. So in the areas of England that have the lowest healthy life expectancy, more than a third of people of working age are economically inactive due to long-term sickness or disability. So that adds up to increased treatment costs, so cost to the health system of treating illnesses, the cost from decreased productivity and the cost of social support. So it's not hard to make that argument either. So if you could go on to the next slide, that kind of sets the scene for the reason that after post-COVID, when the NHS was trying to restore services inclusively, the NHS England set up the National Healthcare Inequalities Improvement Team with the vision below to tackle inequalities. And that work is taking place through a super matrix approach, so really trying to embed it across all activities, all programmes and policy areas, and in the NHS more broadly through activities such as that of clinical audit and quality improvement. There's lots of contextual drivers to support this. So the Health and Care Act in 2022 introduced a legal duty for integrated care boards to tackle health inequalities. It's also part of the NHS long-term plan and the government's Levelling Up white paper. So there's a lot of levers that we can draw on. So if you could go on to the next slide, I think it's important to make the distinction between health inequalities and healthcare inequalities, and the national team's role is in healthcare inequalities. But as you can see from these three different data sources, the estimates of how much healthcare inequalities actually contribute to people's overall health vary between 15 and 43%, with the other proportion being made up of the social determinants. On the next slide is a framework for kind of approaching this, because I think it can feel a bit demoralising. But the director of our team, Bola Awalabi, approaches it in this way, thinking about what are our responsibilities and what can we influence. So healthcare is our responsibility, and we are accountable for tackling inequalities in healthcare, but we can still make a contribution and an influence to the social determinants of health, whilst they might be ultimately the responsibility of other organisations. So the graphic on the left from the Health Foundation shows what the NHS can do as an anchor institution. So due to the size and scale of the NHS as an organisation, there's significant purchasing power, areas for activity and recruitment, buildings and estates, and all ways in which the wider determinants of health can be influenced. Yeah, so thank you. So the next slide is on the CAAW20+5 approach, which I think everybody's probably familiar with. But to summarise, this is the approach through which NHS England is tackling healthcare inequalities across this super matrix approach. So identifying a target population that are facing the greatest inequalities, so the 20% most deprived and plus populations, including ethnic minorities, homeless populations and other inclusion health groups, learning disability and autism, and that's all locally identified by ICSs based on their most at need population. And those clinical areas are really evidence-based, based on where the most impact can be had. And all of this approach is being delivered using QI methodology, with teams championing this approach at all levels. So if you go on to the next slide, we have a really nice graphic of the ecosystem or the architecture through which the CAAW20+5 approach is being delivered by the NHS England team. So several of these are networks really acting at different levels. So the connectors are people of influence in their community who can engage local people. The ambassadors are people working in the NHS committed to health inequalities improvement and really producing some excellent quality improvement projects. The collaborative is a higher level organisation. If anyone's not muted, would you mind muting yourself? Thank you. And the collaborative is a higher level network of strategic partner organisations that have a shared mission for tackling health inequalities. The CAAW20 Plus accelerators on the top right was a programme of 7 ICSs that applied to receive additional quality improvement support to really accelerate their health inequalities improvement projects at ICS level. And there was a great energy and enthusiasm from those projects and lots of shared learning from that network. And lastly, on this slide, the innovation refers to some programmes, including a partnership with the academic health science networks to try and reduce inequalities in access to new medicines and technologies. Because again, when you look at who has access to those, for example, in our children and young people CAAW20+5, diabetes is a priority. There are now effectively artificial pancreas solutions or closed loop systems. But these are, when you look at who's receiving these, it's again the people that are least deprived, and there are inequalities in access. Not on this slide, but key parts of the network. We have finance fellows who are working within finance to help further that economic argument and support business cases for various programmes. And of course, working at all levels are those working on audit and QI as well to deliver that CAAW20+5 approach. So on the next slide, I just wanted to draw attention to one project that's we're working on in the NHS England team, particularly because it started as a kind of grassroots project. It started in one area and was shown to be really effective, initially spread organically quite widely before being picked up to replicate that best practice and spread it across England. So the high intensity use services are providing a service for the less than 1% of England's population, who actually make up 16% of accident and emergency attendances and 29% of ambulance journeys. And they can have quite complex social needs, and this service offers tailored outreach and support. And you can see on the graph on the right, again, the use of A&E really reflects the deprivation. So there's a strong correlation. And the service has a really positive impact on individuals. They attend less, and as such, there's a significant cost saving. Now, on the next slide, I just have some further resources from the NHS England team. So we've, as I mentioned on the left, several structured programmes and networks that people can become involved in to help influence and spread this work. We have some frameworks and guidance, and on the subject of kind of inclusivity, there's digital inclusion framework and an inclusion health framework that can also help guide projects to make sure that no one's left behind. And we have some e-learning as well. And a range of other partnerships have also produced effective work, like the partnership with HQIP and giving some guidance on data. So if you go on to the last slide, the next slide, please. So I wanted to just end with some points on health inequalities, quality improvement, because I think the health inequalities agenda is broad and it can seem quite overwhelming, the scale of the problem that we have to tackle. It's really encouraging that there is so much work and interest going on with this. And as such, I think we can all be reassured that focusing on our own sphere of influence is really effective, and working on projects at local level, at national level, that actually demonstrate impact and effectiveness is the key work, because that can then be replicated to give results. In terms of planning projects, starting with a broad question and an open mind is key. I think in this work where the reasons for the inequality may not be clear, having an open mind about what the solutions might be, and having a co-design and co-production approach with those underserved populations that are facing the inequality as being approached as an equal partnership is really key. Danny talked about some of those challenges with data, and we will have to tolerate imperfection in the data while we're trying to make things change, whilst also furthering improving the ethnicity coding and other challenges. I think we can all champion the data collection, the embedding of that access, outcome and experience data, and make the case to those who might be needing to resource it that we must disaggregate the data to see those inequalities and work out how to tackle it. And finally, we've already talked a lot about networks, and I think that's really key, because whilst there's a lot of enthusiasm in the space, we can all be met with challenges in different places, and which can be demoralising. And I think having a network you can come back to of people that are passionate about doing the same thing can help you problem solve, and then also be an opportunity to share learning and spread best practice. So I would end on the message that we should all be continuing to champion health inequalities improvement and use that health inequalities lens in all of our work. Thank you very much, and I'll hand over for any questions or discussion points.
Charlotte, that was excellent. Indeed, bang on time. So we actually have quite a lot of time here for some questions. Anybody want to fire off with any particular questions? And that these slides will be shareable, and anybody who's arriving late, you'll be able to get a copy of these slides. Any burning questions, or have we kind of solved this problem, so we're okay now, so it's all taken care of?
Daniel, there's a question that's come in on the chat asking about Nowhere to Run and asking the question how much of Nowhere to Run correlates with initial access to the GP service. I wonder if you'd have any information on that, Charlotte.
Yeah, so that's on the high intensity use service. So I should have elaborated that report was written by the Red Cross. It's really excellent, and they deliver a lot of the high intensity use services. So there's obviously, I think, a lot of different levels at which there is high intensity use, and often I think the data shows that high intensity use of GP services, so a high number of GP appointments often kind of might precede high intensity use of A&E. So I think it is really important to address it at multiple levels. But while some of it is health related, and it's obviously really important that the specific health problems are addressed in the right place, be that GP or secondary care, a lot of it is kind of more complex social challenges. So the data shows there's quite strong overlap between people that attend very frequently and health inequalities, hence it being a programme that's been championed by the national team. So actually providing alternative sources of support, tackling loneliness, and providing one-to-one coaching is effectively the method through which people are kind of plugged into much more appropriate services, and the feedback from that is really positive from service users.
That's great, Charlotte. Thanks. Any other burning questions coming up?
We've got a hand up from, is it Fuong?
Yes, hi. Yes, it is Fong. Thank you. I'm just wondering, and I think it's wonderful to thinking about co-designing and co-productions with the service users or our clients. I just wondered in terms of what sort of barriers that you may have come across, particularly for people of minor ethnic backgrounds that doesn't speak English, and whether they actually have a different understanding of the health system. Whether that has been a barrier for you, and what sort of strategies you have used to overcome those barriers.
Yeah, thanks. It's a good question, and I think, and yeah, obviously I agree that is one of the key challenges. And in terms of barriers I think it sort of comes down to the theme of health literacy, and the fact that a lot of our health service is designed for people with a high level of health literacy, which actually doesn't reflect the population and is probably one of a big driver in the inequalities. So ways to tackle that, I think the co-production and co-design from the beginning is key. Things that come out as issues are maybe when that is not when enough resource has not been put into that. So if it needs to be consistent over time. So I think people just coming in briefly, asking some questions and disappearing is not a way to build trust with a community or a group that you're trying to kind of bring into the process. So emphasizing that kind of partnerships as equals is quite important. And some of our programs like the connectors are really focusing on the fact that finding the right links into certain communities or groups that you're trying to target is so effective. Because they are the ones that understand how to represent the views of their community, how to sort of share what some of the barriers are that we might not be aware of, and how to create the solutions. And again, linking in with all of the VCSE sector, there are so many really excellent third sector organisations that are representing specific communities or health conditions that actually can provide those links. So partnering with those, I think, is also a really effective way to try and overcome that. Thanks.
There's a question that's come in about small numbers. That's something that has been taxing us on the analytics community as well. Like we have had dealt with this in the past in various areas, and one obvious thing is using temporal sequencing, so that instead of looking over the past year, we look over the past 2, 3, whatever years it takes to get us to be able to do analyses without identification coming through, because that's why there is a small numbers issue that we don't be able no matter how we present results, that they are not, nobody is identifiable. And so there are solutions that, but actually that the wider big picture to do with analyses and small numbers is something that we are working with other analytic colleagues and will be the basis of one of our methodology advisory groups. We've actually got quite a long list now of topics for the methodology group, but it will come forward probably at the end of this year or beginning of 25 to actually tie this down so that we can actually look at groups without having to aggregate and therefore lose basically all the benefit of trying to use the different codes that are available. I hope that's some kind of answer towards moving towards being able to deal with that problem. Thanks. Any other?
Thank you.
Thanks. Any other questions?
Yeah, we've just got Bren, who's got his hand up as well.
Oh, Bren. Welcome, Bren. Always welcome to have you at these meetings, Bren. Thanks for coming.
No, thank you, and apologies to everyone for being late. Absolutely, I was out in the community with some of my Bangladeshi friends, so really bring that voice straight forward in, really. And Charlotte, it's great to see you again, and thanks for all the work you do for people in communities. There was just a few thoughts, really, and if you've covered it on the presentation, then absolutely I will dismiss myself and leave the conversation straight away. But I was just thinking in terms of the slide that you put on, really, then one of the things that I get reminded of is the amount of time we've got to invest to do this. So we have those polar ends, if you like, about actually we need to address the health inequalities right here and now, whatever. And my limited knowledge and view is that we still need to keep in mind the absolute investment of time. We can use resources, which is money, etc., but I just think time, and sometimes I think we need to be reminded of that, and also by the communities. The second bit really is around trust. So I think of all the measures that are going on at the moment, I think the most important one is trust, whatever aspect of it we're doing, etc. So be keen to have an understanding of what sort of measures you think we should be using around trust, really, because I think it's so important. And Charlotte, absolutely respect and everything you say, but when I hear the word represent, for me, for instance, I can't hope to represent the geographical areas I'm at, or whatever, and neither should I, and neither do I want to. So I'm just wondering if the language can move more towards advocate, so I can advocate my knowledge and experience, but working with a band, I'd never look to represent them. And actually looking at individuals in there, I don't think they would look to represent, but they have advocates that actually will say, this is what my experience. And I think sometimes when we have a representative, the default is we go to that representative, as opposed to actually they can be an enabler and they can be a gatekeeper as well. So I'm really sorry for joining late, and there were just a few thoughts, but again, really pleased and privileged to be on the call.
No, thank you very much for sharing that, and a great point. And I do agree. I think community representative groups, I guess I was using as a term to describe certain organisations, but advocates is a better word. And I think at other levels where it's not actually an organisation, then as you say, that terminology is important when we're looking at individuals. In terms of trust, I think because it's such a key part, almost the success, a measure of success of the trust might be how effective that partnership is. So I think for actually to deliver some meaningful results is already a measure of success that your partnership is based on trust. And your first point was about resources. I would, I appreciate that all of this is in a resource time constrained, funding constrained environment. And I think what we can do is make the case for why it's important, and use the data and use all the different levers in terms of the policy, the guidance documents, and the economic case as to why it's important and why we should be investing in it. Thanks.
Thanks, super. I think probably we need to move on to the key part of this, which is the winners of the competition, for want of a better word. But I want to say, firstly, we were really impressed by all of the applications. Anybody who's put an application in, you're a winner, because you've been doing work in a very, very key area, key for patients, key for clients, key for all of us who are involved in healthcare in its various guises. So I've been allocated to tell you about the two commended, and then Charlotte is going to lead again with the winner. So do we have a slide for this? Thanks. Good. And you have to let me know if we've got a slide for those who commended. Thanks very much. So we have two commended groups, and firstly was South Townside and Sunderland NHS Foundation Trust, particularly the health literacy team, who did a project led by Lorna Dawson. And the judges' comment on this project, which they really enjoyed, was it demonstrating not only collaboration and inclusivity, but also was very innovative. So well done. Thanks very much for all the work, and you are highly commended. And then the second commended is the Cornwall Partnership NHS Foundation Trust, in particular the Health for Homeless team, very important area, Health for Homeless, providing medical services for those who are homeless. And the judges in their review of this commented that they were very impressed with the holistic approach taken and supporting both mental and physical health. So well done, both sets of colleagues, being highly commended for these. I'll now pass over to Charlotte, who's going to present concerning the winner.
Thanks so much. Yeah, it's a pleasure to announce the winner, who is the winners are the Learning Disability team at the East Suffolk and North Essex Foundation Trust for an excellent project supporting people with learning difficulties who might find it harder to communicate. Again, an impressive co-production approach taken with great improvements. Well done, guys. And I think we're now handing over, hopefully, to hear more from the winner on that project.
Hi, it's Roger Blake here. I'm part of a team with Stephanie Baker. I cover Ipswich Hospital and Steph covers Colchester Hospital. Yeah, I'm here to talk about the Learning Disability Constipation Project. Next slide, please. So, yeah, I'm here to talk about poo. It's not a very nice subject. It's a subject that some people find difficult to talk about, but it's really important that we can talk about it in a really clear and open way. We like to think about constipation on a bit of a timeline. So if we imagine that this timeline is the very first time we see somebody at hospital, and the end of this timeline is when somebody unfortunately may pass away. At some point in this timeline, people will have some contact with our hospital. So our project really wanted to make the most of that contact when it counted, to hopefully extend that timeline a little bit further. Next slide, please. So our smart aim was for all patients with a learning disability that come into contact with ESNEFT, whether that be on the primary sites, Ipswich and Colchester, the community hospitals, or any of our community teams, to have some kind of medical input for constipation. Next slide, please. So this is the numbers, the hard stuff. Constipation can be a life-threatening issue for people with learning disabilities. We know that there are heightened risk from the complications if it's left untreated. We know that people with learning disabilities are more likely to have constipation than a person without a learning disability. And it's a registered health problem for nearly 60% of people with profound learning and multiple disabilities. Leader found that laxative prescriptions were received by over a quarter of people with a learning disability, compared to 0.1% of people without a learning disability. So a significant disparity in numbers there. When we're talking about ESNEFT specifically, less than 2% of patients that attended ED in ESNEFT have a learning disability, and less than 5% are actually inpatients when we're talking about learning disability. Constipation was a documented case for 11 people, but in 2023 it rose to 21 as a primary cause of admission. So we are seeing an increase in the actual identification of constipation as being a major issue for people with learning disabilities. 23% of people with learning disability who died has constipation as a long-term condition. So it is a recognised issue by Leader. We've had two very high-profile cases of deaths, unfortunate deaths of constipation in ESNEFT. So we wanted to really do something about this, considering we're seeing this increasing acuity of people coming into hospital. Next slide, please. So our project has three main goals. If you just want to click forward. For every patient with a learning disability, we check for constipation when they're admitted to ED. And the way we did that was we changed our existing, just put all three on, that's fine. We changed our existing reasonable adjustment tool for ED, which is a little sticker with 5 questions on it, to add another question. Has this patient been checked for constipation? That sticker should be completed for everybody with a learning disability who comes into the hospital, which means that hopefully everybody with a learning disability who comes into ED is having some kind of check documented for constipation. We updated all our existing paperwork, including our health passport, our reasonable adjustment tool for inpatients. We changed our existing training within the hospital, and we made our intranet and internet more constipation friendly. The third goal, and probably the most difficult part of this project, was creating an IT solution for every outpatient appointment of everybody that has a learning disability who comes in contact with ESNEFT. I think I heard there was over 2,500–3,000 outpatient appointments per day across ESNEFT. So we had to think big on this, think about an IT solution. That something will come up in front of the clinician when they're seeing a patient for an outpatient appointment, so that they will have a check for constipation. I'm happy to say that this will be included in our new system, our new EPIC system, which will be going live early next year. Next slide, please. So these are some of the tools that I mentioned in the last slide. The purple one there is the sticker for ED. This is our health passport, which has recently been updated. Our intranet page, which now has gladly information about constipation, and our reasonable adjustment tool now has a very clear section on bowel care and constipation. Next slide, please. So the specific aims of our project were for documentation of constipation in patients with a learning disability attending ED and outpatients in Ipswich and Colts Hospital to rise from 0 to 20% by the 31st of December last year, which we did quite easily. And we measured that quite specifically with an audit. The aim was to earlier identify constipation. So that timeline that I was talking about at the very beginning was changed for people with learning disabilities. We wanted to raise awareness and training of constipation as much as we possibly could in this project, with a view then to hopefully assist in admission avoidance long term. We did engage with people with learning disabilities throughout the project, throughout all the sections of the project as well, to ensure that their voice was heard throughout. Next slide, please. So the outcomes of this project, hopefully long term, will be earlier identification of constipation, as I said, admission avoidance long term, less acuity long term, improved patient outcomes because we will identify constipation earlier, improve staff confidence in dealing with complex atypical presentation, which can be a feature for people with learning disabilities. They may have constipation as a secondary issue when they come in, and their initial medical presentation may not be clear that they actually, their real issue is actually constipation. We took into account the STOMP and STAMP program for long-term patients with polypharmacy to, in our training, ask doctors to look at the specific medications that people were on and review them as necessary with a view to constipation. We have a system already in place that people with learning disabilities are automatically prioritized for outpatient appointments. Unfortunately, that does still mean quite a long wait, but people with learning disabilities are prioritized automatically. We made sure that there was adherence to the accessible information standard by making all of our resources as accessible as possible to people with learning disabilities, again with a view to save money, save time, and of course save lives. I think that's it. Thank you very much, and I'm happy to take any questions.
Oh, lovely, thank you, Roger. That was brilliant, and so much that we can all take from that and apply to whatever type of healthcare setting we're in terms of supporting all our patients. I'm just thinking some of the other vulnerable groups such as Frailty Pathway, and you just think that what you've done here we can be applying, can't we? It's fantastic. So have we got any hands up? I think we do. Let's have a look. Marina.
Oh, apologies. Apologies, I didn't mean to put my hand up then. I was trying to do my clapping.
Oh no, I
Getting a
think
bit trigger happy.
it's Marina Quick that's got a hand up, I think.
Hello. Yeah, while I've been listening to these sessions this week, every time Marina has mentioned, my ears were really pricking up. Obviously, you weren't talking to me, so apologies. Roger, thank you very much for talking about poo. I find that really, really interesting. I guess the little sad bit for me as a nurse is that, you know, you even had to be doing this. But it's the situation that we're in, and you know the process that you went through and the impact that you've had it's just amazing. But I did wonder, sort of when you were starting off on this and you realized that there was like a problem and an issue there, what sort of pushback did you get and how did you manage that, if you did at all?
Well, some of the tools that we used in this specific QI project, some of the tools we used were already in place, and we changed them to be able to fit in with the requirements. So, for example, the tool in ED that was already in place, so we didn't really receive much pushback on that. The pushback really was in the IT solution, because what I think is quite a small fix and it's quite easy to do, people in IT disagree. I think it's when you try and take something brand new like this and try and implement it via another team, then inevitably you get some kind of minimal pushback. But I have to say, working with staff, working with the QI team in the hospital, it's been quite refreshing that actually it was quite straightforward to implement some of these things. Yeah.
That's brilliant. Thanks, thanks, Roger. And Naz, lovely to see you on the call. Do you want to ask your question?
Hi, thank you. Roger, great presentation. Really enjoyed listening to that. Gives a real practical example of how we can include health inequalities within a trust. So I loved it. I also love the fact that you shone a light on learning disabilities, which is such an important inclusion group. What I wanted to ask, two questions. So did you work with carers at all? Because I think carers are really important with this kind of world of work with regards to learning disabled patients. But I also wanted to ask, how did you get agreement from your trust that they're going to prioritise in the outpatient department appointments for people with learning disabilities? And did you get any pushback, and how did you overcome that? Thank you.
That's two really long answers required there, I think. So thank you. So for outpatient appointments, I contacted the people in outpatients. I explained the situation in terms of waiting times, talked about the mortality numbers, etc., and they couldn't have been in more agreements with me, really. To me, they all seem like really common sense solutions to quite, you know, if you prioritize people with learning disabilities for outpatient appointments, there'll be less waiting times and inevitably less mortality. So to me, it seems really straightforward and common sense. And I have to be honest, if you know, when I explained it to them and told them the issues, they were pretty receptive to it, to be honest. With regards to carer consultation, absolutely everything we do, we try and involve people with learning disabilities and their carers and their families.
Lovely, thank you. I'm just going to have a quick look in the chat, and Marina NQI Marina, I think there might be a red dot on the Q&A, so I don't know if we've got any questions in there. If you wouldn't mind checking as well.
Check it. I think if someone put one in, it's gone again.
Okay, that's fine.
I did spot that one come in and then going again. But you do have another hand up from Bren.
Oh, yeah, lovely. Go for it, Bren.
Sorry to hug it or whatever, but I'll be as brief, really. I mean, one of the things that came across in the presentation and what you said, Roger, is actually the right culture within your organisation. So again,
Absolutely.
How we measure that is for me anyway, is demonstrable actions. We can have loads of words and definitions of culture, but I think that's what I take away. Well, one of the things I take away, Roger, really, for these things to happen, actually happen on a platform with the right culture. So so don't overlook that really. The other aspect of it as well, really, I'm just wondering on, and I get reminded of this, and I struggle with it, to be honest, but I do understand intersectionality, but I'm not always sure how I would measure that really. So the person will come along, let's say with learning disabilities, we've got the age aspect or all the other aspects of that really. And I'm just wondering how you factor that in within your work or will factor in. And thank you again. Absolutely, I'll put it in the chat box, but I'm going to be asking questions locally, and it's flipping brilliant.
I think when you work in a hospital, you have the kind of luxury of a very kind of ready to hand MDT approach being available to you. So I've been in this trust for almost 10 years now. You know, my face is relatively well known around these parts. So for me to get together a really effective MDT approach for, you know, patients where intersectionality is an issue is again relatively straightforward, and again quite a common sense approach for me. Working outside in the community as well, it's very kind of it's tricky sometimes to get the right people on board to make sure that, you know, the right disciplines, etc. But that's what we do for people with learning disabilities. We go that extra mile. We push. That's what learning disability nurses are for. We push where other people may not.
Thank you.
Just a couple more questions. I know you want to run your evaluation as well, Marina, don't you? I'm just thinking if we could potentially take another one. Yeah, I think key question here, I think Eva's put in, how implementing this practice impacted numbers of people suffering from constipation. Have you seen an improvement yet?
We have seen an improvement. The actual kind of hard data in terms of metrics, we haven't, because we wanted to give it a good kind of 6-8 months before we actually looked at the numbers. But anecdotally, we've definitely seen an improvement in the kind of levels of awareness that people have, what people are doing for constipation. We're getting better feedback in terms of, oh, you know, my son came in, he was really sick, I didn't know he had constipation, and now he's been treated for constipation. It's we've definitely seen an improvement, and once we have the kind of hard data for that, I think it will I think it'll be really hopefully a positive.
Yeah, no, that's brilliant. I'm aware there are a few more questions in the chat, and obviously what we'll do is we will collate them. Just obviously we've only got a few minutes to go now, so obviously if anybody, I mean, Roger, you might be able to respond to a few of the queries in the chat now whilst we're running the evaluation, and obviously we will collate that Q&A and make sure we publish that as well, and obviously we'll put any of the unanswered questions to Roger, Danny and Charlotte as well. So Marina, I don't know if you want to put the link to the evaluation in the chat.
Yeah, I've got it ready to go now.
Excellent. So if you didn't mind sharing your thoughts on today's session, or actually in terms of the whole topic of today in terms of health inequalities and how we can effectively utilise clinical audit, please do complete the survey, because obviously we'll use everything that you feed back to us to shape future events and resources and support that we can all share amongst all of us, really, so that we can look to take this forward in our own organisations and across our systems. And I suppose once we've shared that link, we've got another slide just really to challenge you all a little bit, really. So it's just to build on where we started in terms of some key points for you to take away, because we've heard a lot of information, I think, today, a lot of valuable information that's thought-provoking, isn't it? It's just stretching our thinking to another level, really. So I suppose it's just getting you to go back to your organisations in terms of clinical audit now and starting to think about some of those incomplete data sets, and maybe in particular around some of that ethnicity data that both Danny and Charlotte touched on, but also thinking also about how you can access and understand your local health population data and your local health inequalities improvement plans, really, so that you are supporting the challenges that we're facing with our local communities. And then I know Charlotte very much touched on the outcomes and the experience, so it's making sure that we are triangulating that wealth of experience information that we are gathering, and where we're not gathering it, starting to think, actually, should we need to be gathering this from certain groups and certain individuals and certain patients where we know we could make things better, and making sure we're having those open and transparent conversations with our patients and service users, and maybe starting to think a bit more widely around the patient pathway and working with our partner organisations across our systems to really look at how we can make that better. And bringing it full loop back around to clinical audit, obviously clinical audit's a fantastic QI tool to make sure we're measuring the impact of any improvements that we're making. But again, bringing it back to our patients and service users, it's about really finding out from them, from their perspective, then, did we get that right, those improvements, and have we really made that impact for everybody that's using our service? So it's a big thank you really to Danny, Charlotte, Roger for presenting, and for all our attendees as well for joining us today, contributing to the chat, helping us with that evaluation, and obviously picking up that ask that we've just presented to you for you to take away those objectives back and take those forward in your own organisations. So we've got 2 more events this week from the Lunch and Learns, but we've also got some of the other national events running as well as part of Clinical Audit Awareness Week as well. So tomorrow, Making Data Count, Sam Riley joining us around influencing change, and on Friday, Zoe Lord from NHS Horizons around, well, actually, what's the impact of this, and actually, is it sustainable change that's really future-proof in health and care? And really just to flag as well, we've got the National Centre for the Cancer Audits that have got a webinar tomorrow that you do have to book on, and then a fantastic conversation with Stella Vig, our National Clinical Medical Director, for secondary care, get the title right because it's changed, who Claudia Snedden, our clinical fellow at HQIP, will be interviewing her as well on Friday afternoon. So head on over to HQIP for the links, and we hope to see you tomorrow and Friday at the events, and enjoy the rest of the week. And please do join that Futures platform and let us know about your local events and things that you're taking forward from Clinical Audit Awareness Week. So thank you for joining us, and thank you everybody.
Cheers. Cheers. Thanks everybody.
Bye-bye.
Thank you.